Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I am Dr. Jennifer Miles Thomas, and in today's episode, we will discuss leading urology resident education into the future. Joining me today for our discussion is Dr. Simone Bavasilian, who is a professor of surgery and urology at Brown University in Providence, Rhode Island. She is a fellowship-trained endourologist and has spent 12 years in practice. Her academic scholarship is focused on graduate medical education and diversity, equity, and inclusion. She is the residency program director. She has published on numerous topics, including the urology match, preference signaling, addressing match violations, and developing virtual urology curricula. She has led numerous projects in GME and DEI. She is also the secretary-elect of the Society of Academic Urology, the president-elect of the Society of Women in Urology, on the executive committee of the AUA DEI committee, and part of the AUA Education Committee. Welcome.
Thanks for having me. I'm great. Really excited to be here.
Well, thanks for coming, because this is, if we're talking about the future of our society, if we're talking about the future of healthcare and urology, this is completely something that we should be discussing very actively right now. So can you kind of just start from the beginning? How is your urologic education organized? And how would someone become an educator? Can you talk about how the programs are structured, accredited? Can you just give us the information about this, the baseline about urology education in the U.S.?
Absolutely. We have about 10,000 or so urologists in the country, and the process to get there is long. There are about 145 residency programs in the U.S., and most recently in our 2024 match, 385 students matched out of 500, and that's around a 77% match rate. So it's a competitive subspecialty. We get some of the best medical students to come into our field. But urologic education is really organized around this principle of undergraduate medical education at the medical school level, and then the graduate medical education process that is residency education. There are a number of leadership roles that I think are very familiar to trainees, a program director, an associate program director, and maybe others that are less familiar, faculty that are engaged in all of the administrative and educational structures that exist to have a residency program, which in many cases is a labor of love. And kind of one would say about raising our children, it takes a village to have a residency. And so there's also faculty involved in the program evaluation committee, in the clinical competency committee, in well-being activities and patient safety and quality improvement activities. And then there's typically a medical student clerkship director. And these are kind of the recognized roles. But then there's faculty involved in site director roles in educational programs like simulation or hands-on training. And then also behind the scenes to, I think, understand is that graduate medical education in the U.S. is funded and paid for by the Center of Medicare, CMS, to sponsoring institutions, which are typically either hospitals or healthcare systems that are funding the salaries and stipends of residents who are providing care to the patients of that healthcare system. The sponsoring institutions themselves often also are funding additional salary lines for these residency spots. I get a lot of questions about how we can increase the number of residency spots in urology, knowing that there's such a workforce mismatch between the patient population and the workforce that we have. And a lot of it comes down to those funding opportunities for sponsoring institutions to get additional spots. There's also professional organizations that are deeply invested in graduate medical education. This includes the ACGME, which is the accrediting body of residency programs, to make sure that the program is providing an education that's consistent with the requirements that are necessary to develop a potentially board certified urologic surgeon. And then there's organizations like the Society of Academic Urology, which are faculty and university urologists that are engaged in the mission of education and the work they're doing to make sure that we're preparing the next generation. There's also the organization like the American Board of Urology that certifies individuals in terms of their practice. And then finally, the AUA, the American Urologic Association, that provides so much educational content both to trainees, for example, with the in-service exam and the core curriculum. And these are materials that are used daily by everyone across the country, but also to, of course, practicing urologists. And so All of these organizations have their varying roles within urology education, particularly as it relates to training MDs and DOs in urologic surgery. And of course, there's also other team members in this system. There's nursing staff, there's advanced practice providers that we're also trying to educate. And so the system is very complex, but there are multiple ways to get involved in terms of both leading education in urology or just starting to get your feet wet in terms of training and teaching.
So there looks like there's a lot of opportunities for us to get involved. So how would you suggest someone who maybe is not currently involved in the education of residents, but maybe at an academic center or in private practice, what could we do as individual urologists to be involved with resident education?
Yeah, when we get out and practice, there's just so much of the hidden curriculum that still has to be learned. And those 1 to 3 years of practice, I have a mentor who calls it the pretending years. And you're just trying to get your feet underneath you and gain, confidence in yourself as a independent urologic surgeon. And so sometimes it can be overwhelming to also think, oh, I also have to teach at the same time. Hey, I'm just trying to kind of get myself settled. And there's no specific training in how to teach, but I think we all recognize when we go through training that there are folks that we might have worked with that were very effective in giving us new skills, or we walked out of having had a really great educational experience with them in the operating room or attended a lecture and something clicked for you. And so you kind of think about who your models and mentors are. But when you're new in this, I think the first thing is getting your feet wet with clinical care is really important. And education might not be the biggest mission on your list, but there are many ways to incorporate teaching into your daily activities. And so I think it's easy to start small. And these are my kind of 7 tips about just the day to day. The first is write it down. If you have a new learner in your office, a new student or a resident, you're typically giving the same information to them over and over again. You're trying to orient and onboard them to, this is what you should read. This is how you should prepare. These are the disease states that I treat. This is where, this is how you would write a note. These are my expectations. It's ideal not to have to repeat your message over and over again because that slows you down. And that's kind of one of the downsides of being a teacher. Writing it down in one place and onboarding them efficiently can be really helpful to you. Number 2 would be to find a partner. If you could potentially share a teaching role with a colleague, that can be really effective. That's true for the learner, the trainee as well. If they have a partner, they can work together in a pair. Number 3 would be just recognize that you're role modeling no matter what you're doing, whether it's how you treat patients, how you counsel patients, how you engage with your staff. A trainee or student is watching everything about how you approach this. So recognize just being a role model is sometimes sufficient. My 4th tip is just talk out loud. The decision-making that experts have, they arrive at after years of training, but it becomes second nature to them. So much to the point where they take for granted that they are able to look at data, synthesize it, and make a decision that can influence patient care very quickly and effectively. They are doing that in clinic, usually seeing a ton of patients, engaging with the EMR, engaging with patients. If you can talk aloud a little bit of your surgical decision making or your clinical decisions, that's really effective for learners to hear that process. The 5th would be ask students to teach, because if you are asking them to master a certain area or topic and they have to then deliver it or teach it, they will master it even more. My 6th tip would be to kind of think about your teaching scripts, the things that you might want, those pearls and tips and tricks that you want to get across to a trainee in terms of where you are. So for example, if I'm in the operating room, I'm really going to focus on surgical management of stone disease. But if I'm in the office, I'm going to focus more on medical management of stone disease. And so you might have your scripts ready to go and think of them in terms of where you are, in the hospital, in your day, that are kind of site specific. And finally, my 7th tip in terms of just the day-to-day of incorporating teaching into your really busy clinical workload is to have a trainee or learner look it up. And I'm having, learners and trainees can always ask questions that sometimes you don't have the answer to. And it's really helpful because they have really well-developed research skills to be able to look up information and add to your fund of knowledge or their fund of knowledge and your working knowledge. And so I think those are the ways to just incorporate it. And that's true for senior residents. It's true for private practice doctors, and it's true for academicians. I think the other thing for me that has helped over the course of my career is really questioning the limiting belief that education as mission isn't as hardcore as research, and I think you can approach educational research and have a career as an educator and really develop that as a clinician educator with the same process and kind of basic training or applying the principles of research to educational research. Basic frameworks like the Swish scale of entrustment and autonomy, educational summary reports, Kirkpatrick's pyramid, or Bloom's taxonomy. These are all basic frameworks of how learners learn and how teachers can teach. And the goal here, the outcome that you might assess, where you're quite used to thinking about this in clinical medicine and the outcome of an intervention or surgery or medication. The outcome in the educational world is change in knowledge, change in attitudes, change in beliefs. And so you can assess those outcomes in your learners and trainees and see if they're changing and adjust your study design or your educational intervention, be it a simulation exercise or a didactic talk or a case-based presentation, and measure those outcomes, and then potentially, share it, disseminate it, publish on it. Over the course of my career, the types of papers and manuscripts that I've published have focused on GME and for example, examining the trends of underrepresented minorities in urology, or what are the challenges and opportunities that women in urology in the workforce face, or how can we improve match guidelines and match behavior so we have a more ethical process? How can we incorporate preference signaling into the match and improve the interview selection process? What are the disparities associated with gender of industry payments? These are all, publications that help influence kind of the knowledge base around graduate medical education, and for me in diversity, equity, and inclusion, and can be academic products and scholarship products in the same way that you might think of as research projects and research papers.
So that was great. That was a lot to think about, but there's an opportunity for everyone. And thank you very much for the framework. You really broke it down into simple facts. Here are a few things you can do that don't require a lot of effort, but really make a difference. And I love the fact that you were like, just talk it out. There are so many things that are just automatic for us now. We're seeing 30, 40 people in the office. It's just X, Y, and Z, but we have to recognize they have not seen that before. Their process is different. And if we're talking it out, it's better for the patient. They understand that whole kind of thought process, and it's great for the trainee also. So thank you. Mm-hmm. Well, what other professional development resources would prepare you for a career in education?
Some of this is trial and error. I got to be honest. You show up in an academic position, you have trainees, they're waiting to learn from you, and you're just trying to figure it out as you go along. But there are many medical schools, professional development programs for educators, and typically promotion tracks that are specific to clinician educators so that you can develop some of the skill set around designing objectives or goals for an educational intervention, or designing a curriculum so that you could develop, a change in knowledge of your trainees or a change in skill set of your trainees. Many urology residencies, for example, are doing some sort of hands-on simulation curriculum. Maybe it's robotics training, maybe it's endourology, maybe it's BPH procedures. And in many of these situations, they are collaborating with industry partners who have access to some of the resources and training models that they might bring in. And these are all great opportunities for you to potentially develop a curriculum, assess its outcome, and then disseminate and share it. In addition, at most medical schools, there's also other opportunities for professional development that include kind of apart from developing your skills as an individual educator, developing skills in leading the administrative aspects of education. So, program directorship or clerkship director role. And then, of course, also educational research. And so just like you would think about additional stats training to develop your research career, similarly in education, you would think about educational research. And so how do you develop goals and objectives? How do you assess outcomes? What are the survey tools that are appropriate to assess learner outcomes? And then there are a number of avenues to publish and disseminate your scholarship in this area. And so I'd like to really recognize Gold Urology and Urology Practice Journal. They are two that are really open to educational content, and a lot of key leaders in urology that are publishing will publish in these journals. And of course, the Journal of Urology as well. But outside of urology and our subspecialty, there are many other journals. So for example, the Journal of Graduate Medical Education, Academic Medicine, Medical Teacher and Medical Education, the Journal of Interprofessional Care, Medical Science Educator. These are all publications that really focus on just educational topics. And as you get exposed to them, you start to see that there are many educators in other fields, surgery or even, medicine fields, that are all engaged in some of the similar challenges we all face in trying to teach learners in a compressed time when there's multiple competing demands on the resident in a very complicated ecosystems of the healthcare systems that we work in, trying to kind of come up with solutions for all of these issues. Also, for example, the AAMC has a med ed portal where you might give a talk. Let's say you do a case-based presentation on urodynamics, and it goes well with your trainees. And you've developed the materials associated with that. Maybe you have a PowerPoint presentation and a handout. All of that is potentially publishable through the med ed portal as long as you're assessing outcomes. And you can publish the content of that educational summary so that other teachers across the country can use those same materials and execute that training. And so there are a number of avenues for scholarship there, but medical schools have really taken the opportunity to develop those resources for educators as well.
Well, I was never aware of the AAMC MedEd portal, but that's exceptional, because a lot of us put content out there and just share it with our residents. But the fact that it could be something that's internationally observed, and the more people that we educate, the better. So you talked about competing interests with the residents. There's so much to learn besides just the clinical content. What about for urologists? All of us are very, very clinically busy. We know about the workforce shortage. So why should urologists get involved with education?
There are so many competing demands on our time. And, the clinical burden is great on urologists, seeing 30 to 40 patients a day, operating, managing call. These are all day-to-day things that are super relevant to urologists trying to maintain a sustainable career. And so there are benefits and downsides, like anything else in life, to be an educator and to be involved in education. My personal belief is when you look at that balance, it tips in favor. But the way I see them overall is, some of the benefits is that you stay current. When trainees are involved, they're always asking questions. They have access to kind of information in ways that are greater, certainly, than 10, 15 years ago. And so you're forced to stay current. You get to connect with the next generation. And, I say that I keep getting older, but the trainees keep getting younger. And it can be very nice to interact with the next generation. I will also say I have a fellow, Dr. Gainey Simons, for example, who I might mentor, but she really reverse mentors me, and I learn from her. And if you're not engaged in those educational relationships, that's a little bit harder, but it is so appreciated that I get to learn from her by virtue of being involved in education. You get to develop a legacy of mentees. I think about when urologists, particularly in mid-career, are trying to think about what is my impact, in urology, what could be the legacy of my career. The legacy you have an impact on people, I think ultimately has the greatest influence. And so the opportunity to teach that next generation, develop a cadre of mentees and see what they do and where they go, it's almost like your work as a urologist that has that much more impact. I also, strongly believe that the urology residency workforce is some of the most efficient workforce out there. And they are taking care of the most complex patients at the tertiary care academic medical centers. They are on the front lines answering the pages from nursing staff at 2 a.m. in academic programs. And the care that they're providing to patients, even as they are learning, is really critical to those patients. The attending surgeon might be the captain of the ship and leading the team, but the reality is that residents are caring for our patients in a way that is really appreciated. And maybe that doesn't seem that way to trainees in the thick of it, but the reality is that is what they're doing. They're providing a significant service to patients in the most complex care settings. I think from a faculty perspective, teaching also offers you an opportunity to refine your skills and then really focus on demonstrating mastery when you have to teach it. So for me, as I've kind of matured in my career, there's certain operations where I can really take a back seat and watch. And I'm not saying that this is stressful, because entrusting a hilar dissection or handing off the scope to a trainee who's very, very new is actually anxiety producing in some situations. And I think we should normalize that. Because you're faced with the question, well, if things do go sideways, can I right the ship? Can I undo that? How much entrustment should I give before maybe I've gone too far or too little? And those are always judgment calls and you're always practicing that. But the opportunity to teach really forces you to have mastered your craft. And I like that opportunity. And I think that can be really meaningful for faculty. And of course, there are downsides. So it can slow you down. The more you have a trainee who's novice, if you truly want to engage them, it might take more time. And as I mentioned, the issue of entrustment can be stressful. And so you have to have ways of managing that. I think the most successful educators will figure out what are the pieces, the leading edge of a case that I can hand over. What are other parts of the case that I really can't hand over and I'm going to make quicker progress with? Where is the leading edge of growth for the trainee for this operation? Can we focus on that piece of it for this amount of time so that you maximize their learning, but also continue the clinical care? Because the reality is residency is a training program, not a student education program. And so you're learning on the job, and we are really focusing on trying to take care of patients. So again, when I look at it, I'd say the sum is really in favor of those benefits. But I do think there's a key tension underlying all of this. And that is that if the tripartite mission is clinical care, followed by research, followed by education, and maybe we add a fourth leg to that stool of well-being, there's still a tension between all the clinical work we need to do and then the educational mission. And that tension, for example, as a program director, can be really challenging to manage because there are resources that you need to be able to make residency education more effective, and sometimes you don't have access to those resources. Or the reality is that patient care always does come first and ahead of education. Or the introduction of robotic surgery into urology, which makes entrustment that much more difficult because you're not shoulder to shoulder with your hands in the abdomen as you operate together. And so these tensions, they don't go away. They're not a problem that can be fixed. And speaking as an endourologist, I like surgical problems that have a surgical solution, because for me, that is like maximizing satisfaction of the work. And so I think that tension and navigating and managing that tension is something that never goes away. I'd also add here that I think private practice physicians are a key demographic to be involved in education in some aspect. Of course, with residents, but also with all the staff that surrounds us, advanced practice providers, nursing staff. We're constantly faced with having to educate new folks into the world of urology. And I think these urologists are also managing the broadest spectrum of urologic disease. And issues related to practice management. And so there's a whole hidden curriculum that I think most residency programs try to provide urology trainees. Most residency programs are occurring in an academic setting. But there's a role there for private practitioners to be involved as well. And I think in general, most urology residents are really appreciative to get that opportunity to see into that world and see practice up close and personal that is outside of the academic sphere. And how to manage that, how to optimize it, how to provide, the greatest amount of clinical care in the time that you have in efficient in ways. I'd also add that one of the big benefits of getting involved in education is that we do have a need to really diversify the urologic workforce so that our urologic workforce can represent our patient population. We know that outcomes when the patients see, either race or gender concordant physicians are better. And that diversification of the workforce is certainly going to take time, but there are a lot of really exciting pipeline programs and many urologists working in this area to improve that. And, so these are also opportunities for urologists to get involved, particularly in mentorship and sponsorship, to try and improve diversity in our field. So Chanel Wilson runs Urology Unbound. They're looking for volunteers and faculty who might want to take not even that much of their time to mentor students who are applying to urology. Michigan Urology Academy, the URDR program, Prospect, which is a research consortium that Linda McIntyre leads with the North Central section, AUA Future, which is a pipeline program through the AUA led by Dr. Bressler and Dr. Denise Asafua-Deje. These are all pipeline or pathway programs to introduce urology to students who are early in their career, and some even before medical school, so that they're exposed to urology and want to potentially pursue a career, and also are given the resources to develop a CV and an application that's competitive to be able to match in our subspecialty. There are also a number of affinity organizations who are looking for volunteers. And these are, ways to get involved in education that don't necessarily involve your day-to-day clinical work. Organizations like R. Frank Jones or the Society of Women in Urology or Latinx or Pink Trigones, affinity organizations that are bringing together urologists who otherwise are a very smaller community within the entire subspecialty to create community and network. and as I said, diversify a field.
Thank you. Yeah, there's a lot of opportunities that are clinical, and thank you for actually pointing out all the ones that are non-clinical for the next generation, even before med school. Well, one of the things you mentioned was robotics in urology, and that's kind of my generation as one of those newer innovative techniques. So what's new and what's innovative in your urologic education?
Yeah, gone are the days of reading Campbell's to figure out, or maybe even Hinman's to figure out how you're going to do your operation, and looking at the pictures and saying, okay, these are the steps of the surgery. So maybe we could start with the urology match. A lot has changed with the urology match, some, related to the pandemic. But for example, we now have nationally coordinated synchronized interview release. So that we can have more order in the process for students. We have had virtual curriculum like the New York Empire series or the UCSF COVID series, where national experts did virtual talks that students continue to refer to on YouTube. And the AUA similarly has a number of educational products that deliver asynchronous educational content, most commonly either in video format or in electronic format, so we can meet and get that information to learners when they want it, and not necessarily in the context of lecture or et cetera. Also, the AUA fundamentals course and the intern academy with a hands-on component led by Drs. Badalato and Hampson and Osama and Ghazi. This is kind of a really big effort to, now that PGY1 urology trainees are in a fully integrated 5-year categorical program, to make sure we're providing really some of those basic skills and hands-on skills that are necessary for the most junior students who are now transitioning to physicians. I'd love to call out also Dr. Ghazi's work at Johns Hopkins in simulation and the high fidelity models that he and his colleagues have developed, so that he can train both learners, but also practicing urologists on new procedures so that they can incorporate, for example, HoLEP and no BPH technology and emerging technologies into practicing urologists' workflows, which can be a challenge once you get outside of the educational environment. How do you incorporate new technology into your practice? Dr. Abhinav Khanna's work on using AI to convert video content, because again, accessing video to prepare for surgery from a trainee perspective is pretty critical. But looking at an entire video can't be necessarily effective when you're trying to work on a single step. So let's say a resident wants to improve their ability to do an anastomosis. It would be ideal to focus on the anastomosis portion of the video. And so he's using AI content to convert that video into digestible and usable clips so that you could direct teaching and get reps in a small amount of time on the areas that you want to focus on, so that we can really coach technical skill more effectively. Also across the country, a couple of exciting things: regional boot camps. The New York section, for example, runs one. The New England section is running a regional simulation course. Some of the benefits of this is getting trainees together, bringing that hands-on kind of experience and resources, but also the networking within urology. One of the things that I say is probably the best about our field is that we are a small field, and you get to know people across the country pretty quickly because we're a small field. This gives the trainees an opportunity to develop a network kind of regionally. The residents start to meet each other. They then, I think, go on to potentially see them, 5 years, 10 years at a meeting, and these relationships start to bear fruit. There's also emphasis within modern urology residency on well-being and longevity in our careers. How do we sustain that motivation that we all have? Because you don't get this far without motivation. But the reality is that clinical practice is still complicated, and besides burnout and payer issues and volume of patients, the healthcare system, it's a little bit chaotic in the setting of COVID and everything else. And how do you manage all of that? And so Aditya Baroglia, for example, he does a great podcast, Backtable Urology. Phil Perazio, Operating with Zen, another great podcast. They talk about what I would refer to as the hidden curriculum. How do you manage complications? How do you organize your workflow in the office? How do you maintain sanity as a urologic surgeon with all of these competing demands? How do you work on coaching maybe your mindset? How do you navigate a transition in your career where you're moving away from one thing, but you're trying to reinvent yourself in another way? And so working smarter and not harder, I think these are all areas within, again, connecting this to education that urologists are dying to hear about, and it's being shared through these mediums. Finally, I would also say that it's fundamentally a privilege to potentially train the next generation of urologists. It's meaningful work. It's not necessarily easy work, and it can be stressful work, but it's meaningful work. And so sometimes amid the burnout, if you have a meaningful project, you can have an impact. And I think we all know some of those people along the way, whether it's residency or in practice, that have really gone out of the way to give us a hand and help, and made us who we are. Maybe as a surgeon, maybe you do this technique the same way that Dr. X does it, and so, and it becomes part of the fabric of your practice. And so you can have that impact on the next generation as well. And I think that is what, amid all this innovation, has not changed.
I would agree. Yeah, the impact is your legacy. It is our right and our obligation and our privilege to train the next generation, because they are the ones who will be taking care of us also.
Such a great point.
Definitely. Well, thank you very much, Dr. DeFazilian, for sharing your time, your expertise with us today. I would also thank our audience for joining us on the AUA Leadership in Business podcast.
Thanks for having me.
Invest in your leadership and business skills at AUA 2024 with the Institute for Leadership and Business track. The ILB track features a total of 7 live courses offered from Thursday, May 2nd through Sunday, May 5th, with additional on-demand content to supplement. Whether you are starting your career, seeking career advancement or professional development, or looking to master the business challenges facing today's urology practice, the ILB track offers education to support your needs and professional growth. To accommodate the busy and robust schedule of AUA 2024 and to ensure that participants have access to all programs in the ILB track, each session will be recorded and can be accessed on demand, unless otherwise noted. Visit auanet.org/AUA 2024 to learn more and add the ILB track to your annual meeting registration. See you in San Antonio.